A 19-year-old female returns from Ghana. She presents with pyrexia, 40 degrees Celsius. She complains of bloody stools preceding this. On examination, she has abdominal distension, hepatosplenomegaly, and rose spots on her abdomen. Sounds like, what's this called? Shigella? Is it called Shigella? What's that? Something spread by something Mary. Don't remember. Before empirical treatment has started, she passes away due to bowel perforation, resulting in overwhelming sepsis. Which organism is responsible for this type of pathology? Typhoid, yes. It's typhoid fever, spread by typhoid Mary. Historically, that's where it got its name. It's Salmonella typhi. Typhi. Let's see if it's correct. Yes. So, Salmonella typhi infection can cause rose spots on the abdomen. Rose spots appear in Salmonella typhi infections. They also appear in Clostridium psittaci infections, although it's more associated with typhoid than psittacosis. So the reason I had the thought of this being a typhoid fever straight away because of the rose spots. So other features we can learn from this is she has abdominal distension, hepatosplenomegaly. Okay, that's quite deadly. Giardiasis would not present this severely and acutely. Syphilis would present with painless chancre. Staphylococcus aureus would present with within hours following ingestion and is associated with violent vomiting. Streptococcus pneumoniae does not usually cause gastroenteritis. Okay. Let's read a bit about this enteric fever or typhoid fever. The Salmonella group contains many members, most of which cause diarrheal diseases. They are aerobic, gram-negative rods, which are not normally present as commensals in the gut. Typhoid and paratyphoid are caused by Salmonella typhi and Salmonella paratyphi, types A, B, and C respectively. They are often termed enteric fevers, producing systemic symptoms such as headache, fever, arthralgia. Pathophysiology, typhoid is transmitted via the fecal-oral route, also in contaminated food and water. Features initially systemic upset as above, relative bradycardia, abdominal pain, distension, constipation. Although Salmonella is a recognized cause of diarrhea, constipation is more common in typhoid. Rose spots presents on the trunk in 40% of patients. They are more common in paratyphoid. So paratyphoid and typhoid are different, huh? Salmonella typhi and Salmonella paratyphi. Let's see some pictures of rose spots. Okay, so these are rose spots. That's how it looks like. Possible complications include osteomyelitis, especially in sickle cell disease where Salmonella is one of the most common pathogens. There is a reason why some organisms are more common in people with sickle cell disease. It's because their spleen dies sometimes. So, how do we say this? In sickle cell disease, there's a high tendency of your red blood cells causing a clot to your spleen. and then it will cause something known as autosplenectomy, which means your spleen just dies on its own. The reason being you have spontaneous blood clot forming in the artery supplying blood to your spleen. Then this starves your spleen of oxygen and your spleen dies. And when somebody doesn't have a spleen, they are more susceptible to certain organisms, to infection from certain organisms. Yeah. I can try and find some information on it. Autosplenectomy. Self removal. Negative outcome of disease and occurs when a disease damages the spleen. Yeah. They become more susceptible to certain organisms. Yeah. They become more susceptible to encapsulated bacteria. Encapsulated bacteria. And Salmonella typhi is one of them. Okay. Possible complications include osteomyelitis. Okay, we've mentioned this. GI bleed or perforation, meningitis, cholecystitis, chronic carriage. 1% more likely without females. Okay. We go to the next question. A baby is born at full term following a vaginal delivery, complicated by a shoulder dystocia. This is an emergency. The baby is born in very poor condition, and accordingly, the neonatal team resuscitate and intubate the baby. The baby is profoundly acidotic and demonstrates global hypotonia with abnormal neonatal reflexes. The neonatal team decide on the most appropriate step in management as they are concerned about hypoxic brain injury. Which intervention is most important for this baby? So if you're concerned about hypoxic brain injury, what do you do? Sodium bicarbonate correction, blood transfusion, skin-to-skin contact with mom, therapeutic cooling, vitamin K administration. I think it's therapeutic cooling. Okay, let's look at the answers one by one. Sodium bicarbonate correction. Why would this help? Unless they are in acidosis? Yes. The baby is profoundly acidotic. Does correcting the acidosis help prevent hypoxic brain injury? I'm not sure how it can be. It's related. It might be the answer, but I'm not sure. Blood transfusion. Blood transfusion has its own risks, and this baby is not losing blood, so I don't see why he needs a blood transfusion. Skin-to-skin contact with mom, this is important, but not this if the baby is well enough to be with mom. In this case, it seems like the baby needs urgent care, maybe in the NICU. Yeah, because the baby needed resuscitation and intubation, so definitely not stable enough to be with mom. You need to monitor the baby and treat the and prevent the hypoxic brain injury in this case. So therapeutic cooling, what it does is it reduces the metabolic activity, so it reduces your oxygen demand, I think. And so it as oxygen demand reduces, the stress on hypoxia reduces as well. I think that's how it works. Vitamin K administration, this is for I think clotting disorders. Let's see what's the answer. Yes, the answer is therapeutic cooling. Therapeutic cooling at 33 to 35 degrees attempts to reduce the chances of severe brain damage in neonates with hypoxic injury. Okay. Therapeutic cooling is the correct answer. This case describes a baby with poor APGAR scores following a traumatic delivery with acidosis and persisting poor neurological status. The baby is likely to meet the TOBI criteria for therapeutic cooling and is the most important intervention in terms babies for reducing the likelihood of significant hypoxic ischemic brain injury. A sodium bicarbonate correction is incorrect. Although its use may be considered in severe acidosis, administration is not essential and would not be protective against hypoxic ischemic brain injury. Okay, so it can be considered to correct the severe acidosis. May be considered in severe acidosis. It's not essential. It's not protective. Yeah. Blood transfusion is incorrect. There is no suggestion of blood loss from either the baby or mother. Skin-to-skin contact with mom is incorrect. It's important for both maternal and neonatal well-being, however, not essential. The priority is stabilization and management of the baby's hypoxic injury. Vitamin K is incorrect. Although all babies should receive vitamin K at birth to prevent hemorrhagic disease of the newborn, it will not reduce brain damage from hypoxic injury. Cool. Here's some more detailed information on cooling and how it works. I think it's worth going through it quickly. I think so. Something new, if not come across. Therapeutic cooling. Therapeutic cooling, otherwise known as therapeutic hypothermia, is the deliberate lowering of a patient's body temperature. The intention of this is to cool the brain and subsequently prevent brain damage. Several therapeutic uses for cooling have been proposed. These include as neuroprotection during open heart and neurosurgical procedures, in patients following a return of spontaneous circulation post-ventricular fibrillation arrest, in patients with trauma, head injuries, in patients who have suffered acute ischemic stroke, in neonates with moderate to severe hypoxic ischemic encephalopathy. Of these, the only use whose efficacy in regard to reduction in mortality and neurological morbidity has been consistently proven in existing literature as the use of therapeutic cooling in neonates. The use of therapeutic cooling in the treatment of carefully selected term neonates with moderate to severe HIE, hypoxic ischemic encephalopathy, has been recommended as standard care by the National Institute of Health and Care Excellence. Nice. It has been shown in studies to decrease mortality and improve the neurological and neurodevelopmental outcomes of treated neonates. Hypoxic perinatal brain injury is caused by a decrease in the amount of oxygen supplied to the infant's brain just prior to or during the process of labor. Neonates who survive a hypoxic brain injury can develop HIE. HIE occurs in an estimated 2.5 out of 1,000 term births in developed countries and 26 out of 1,000 term births in the developing world. An estimated 10 to 60% of infants with HIE die during the neonatal period, and an estimated 25% of those who survive suffer from long-term neurological impairment, including epilepsy, mental retardation, or cerebral palsy. Therapeutic cooling remains the only intervention shown to reduce neuronal damage caused by perinatal hypoxia. However, research into pharmacological agents that may be effective is ongoing. The pathophysiology of hypoxic brain injuries. Magnetic resonance spectroscopy studies in term infants with evidence of intrapartum hypoxia and moderate to severe encephalopathy have supported a biphasic model of neuronal death. Primary neuronal death occurs at the time of MR spectroscopy studies in term infants with evidence of intrapartum hypoxia and moderate to severe encephalopathy have supported a biphasic model of neuronal death. Primary neuronal death occurs at the time of severe ischemic insult. Secondary neuronal death, resulting in irreversible failure of mitochondrial function, occurs after a period of at least 6 hours post-ischemic insult. This model of neuronal death suggests there is a latent period between the successful resuscitation and reperfusion post-primary neuronal death and secondary neuronal death. This period of approximately 1 to 6 hours provides a therapeutic window for neuroprotective intervention. Therapeutic cooling is thought to influence the extent of secondary neuronal death in a multifactorial manner. The exact way in which it achieves this is not fully understood. Existing studies that suggest it is related to the reduction of cerebral oxygen consumption, an increase in hemoglobin oxygen binding affinity, inhibition of the synthesis, release, and reuptake of neurotransmitters and neuromodulators, including glutamine, glycine, GABA, dopamine, norepinephrine, serotonin, and adenosine, the reduction of nitric oxide and other toxic free radicals. Criteria for the use of therapeutic cooling in neonates. Neonates with a gestational age of more than 36 weeks or more, and birth weight of more than 1,800 grams, more than 1.8 kg. Okay, so this baby has to be term. It has to be more than 36 weeks. 36 weeks or more. So maybe it's from 37 weeks if I'm not mistaken. When is the term baby? Man, I forgot the basics. Yes. In the past, a baby born anytime between 37 weeks and 42 weeks was considered term. A pregnancy is now considered full term at 39 weeks. Yeah, so by 37 weeks is known as term. Okay. So 1 week before term and after, or more than 1.8 kg. History of acute perinatal event during delivery associated with period of hypoxia. Acute perinatal event during delivery, such as the shoulder dystocia, associated with a period of hypoxia, or an APGAR score of less than 5 at 10 minutes, or at least 10 minutes of positive pressure ventilation. Severe metabolic acidosis on cord gas or blood gas taken within 1 hour of birth. Evidence of moderate to severe hypoxic ischemic encephalopathy demonstrated by onset of seizures or on the basis of clinical assessment of consciousness level, spontaneous activity, posture, tone, primitive reflexes, and autonomic systems. EEG is useful in determining eligibility by detection of abnormal neuronal function or seizures. Treatment must be initiated within 6 hours of birth and continued for a period of 72 hours. Target temperatures, rectal or esophageal, of 33 to 34 for whole body cooling, 34 to 35 for selective head cooling. Following cooling, rewarming should be carried out slowly, 0.5 degrees Celsius every 1 to 2 hours over a period of 6 to 12 hours. Therapeutic cooling should not be offered to moribund infants. Moribund means that they are almost dead. Does that mean moribund? Moribund at the point of death. Yeah. In terminal decline, lacking vitality or vigor at the point of death. So no point giving it at the point of death. Infants with major congenital or genetic abnormalities where aggressive treatment is deemed inappropriate, or infants with evidence of severe head trauma or intracranial bleeding. So these are beyond saving. We shouldn't try to do anything that's too radical, you know. Okay. Only done by neonatologists. Okay. Must have access to imaging. Methods, whole body or selective head cooling. Whole body is often used, easier to set up, less expensive, easier access for EEG. Temperature continuous monitored throughout the treatment, either rectal or nasopharyngeal. Complications. These are the complications. Okay, get a overview of what it is already. Other uses have not been proven yet. So it has been proven for neonates with moderate to severe hypoxic ischemic encephalopathy. Lack of evidence for less severe ones. And those with lower gestational age. So currently it's only recommended for neonates more than 36 weeks. Okay, next question. Ankle brachial pressure index. Please select the ankle brachial pressure index that is most likely to be present for the scenario given. Each value may be used once, more than once, or not at all. A 73-year-old lifelong heavy smoker presents to the vascular clinic with symptoms of foot ulceration and rest pain. Oh no, rest pain. It's already a sign of critical limb ischemia. On examination, her foot has areas of gangrene and pulses are impalpable. Is it sudden acute? Foot ulceration, there's no sudden acute pain, so it's not acute limb ischemia. This is a critical limb ischemia. Oh, you want me to guess the ABPI? Usually measure the ABPI, but I'm gonna guess it's less than 0.3, which is critical limb ischemia. A 63-year-old man presents with a claudication distance of 15 yards. How much is yards in meters? Because I don't live in this system. Oh, it's more or less about 1 yard to 1 meter. So 15 yards about 13.7 meters. Okay, that's not very far. He is a lifelong heavy smoker. On examination, his foot is hyperemic. Okay, there's a lot of blood, congested with blood, and there is a small ulcer at the tip of his great toe. He is a lifelong heavy smoker. His foot is hyperemic. Why would it be hyperemic if there's peripheral arterial disease? Is it because of the collaterals? And there is a small ulcer at the tip of his great toe. Estimate his ABPI. It is less severe than the previous one. The previous one is already have rest pain. This one still can walk about 15 yards, so I'm gonna guess about 0.5. A 77-year-old morbidly obese man with type 2 diabetes presents with leg pain at rest. His symptoms are worst at night and sometimes improve during the day. He has no areas of ulceration. Leg pain at rest again. No areas of ulceration. Worse at night, sometimes improve during the day. What is going on here? Is it atherosclerosis? Why would it improve during the day? Why would it be worse at night? Leg pain at rest is already critical limb ischemia. However, improve during the day, so he doesn't he walk during the day? No areas of ulceration, probably trying to indicate it's less severe than number 3 here. And you need to know that in type 2 diabetics, at least in exams, and in real life as well actually, their ABPI will be sometimes higher than normal because of the atherosclerosis, the hardening of the artery. Arteriolosclerosis or atherosclerosis. Arteriolosclerosis, hardening of arteries. Yeah. Am I correct? arteriolosclerosis, hardening of arteries, yes. He has no areas of ulceration. Sometimes improve during the day. Are you trying to tell me that it'll be high? Or it'll be low, but just not as low because of the arteriolosclerosis? Anyway, these are not good questions. You're asking me to guess the ABPI when you can just measure the ABPI using a blood pressure cuff. Oh, I got it correctly. So number 3, this is critical limb ischemia. Values of 0.3 are typical in this setting and urgent further imaging is needed. Debridement of necrosis prior to improving arterial inflow carries a high risk of limb loss. Okay. Hyperemia may occur in association with severe vascular disease and is referred to surgically as a sunset foot. ABPI is usually higher than 0.3, but seldom greater than 0.5, especially when associated with hyperemic changes and ulceration. Urgent further imaging and risk factor modification is needed. Okay. Type 2 diabetes may have vessel calcification. This will result in abnormally high ABPI readings. Pain of this nature in diabetics is usually neuropathic, and if a duplex scan is normal, then treatment with an agent such as duloxetine is sometimes helpful. Why are you giving duloxetine? Is it for neuropathic pain? Yeah, SNRIs work for neuropathic pain. So this leg pain at rest is actually a neuropathic pain, not a critical limb ischemia, huh? Because it's weird that it improves during the day. Anyway, not very good question in my opinion. 1 to 1.2 is normal, 0.9 to 1 is acceptable, less than 0.9 is peripheral arterial disease, less than 0.5 severe disease. Different websites has different ranges for ABPI. Some say 0.3, less than 0.3 is severe. 0.3 to 0.5. 0.5 to 0.8 is moderate, I think. ABPI is a good test. Values less than 0.9 have been shown to have a sensitivity of 90%, specificity of 98%. For peripheral arterial disease, quite specific and sensitive. Compression bandaging is generally considered acceptable if the ABPI is more than 0.8. Okay, next question. A 76-year-old lady has spent a week on the ward following a surgically repaired neck or femur fracture. Serial blood test reveal. So the date and the platelet counts. On 10th of October, platelets normal. Then after that it dropped and dropped further after 8 days. So what's going on? On 19th of October, she develops a large DVT in her right leg, and the consultant believes this series of events may be drug-induced. Okay, so what did they give her after surgery? Which of the following is the most likely cause of this presentation? What's causing platelet drop? Aspirin, does it cause platelet to drop? But it will prevent DVT. Heparin, metformin, oxycodone. I have no idea actually. So aspirin is an antiplatelet, so is clopidogrel. Low molecular weight heparin is an anticoagulant. All of these are blood thinners to prevent clotting. So these all work to prevent DVT. What drug could induce DVT? metformin or oxycodone. Oxycodone is usually used for pain relief. It's an opioid. It's a type of opioid. It's stronger than morphine if I'm not mistaken, and has a higher risk of constipation compared to morphine, but lower risk of nausea and vomiting. Would it cause increased clotting? And what's the reason for the drop in platelet? Metformin, does it cause a drop in platelet? Does it cause DVT? I've not heard of it. I'm just gonna guess oxycodone here. Yeah, so I was wrong. The correct answer is low molecular weight heparin. So heparin-induced thrombocytopenia is a prothrombotic state. This is so weird. Let's read on. Though rare, heparin-induced thrombocytopenia is an immune-mediated response to heparin exposure, which entails an increased risk of developing venous and arterial thromboembolism. It occurs when molecules of the cytokine platelet factor 4, PF4, bind to heparin to form an antigen. This antigen is then recognized by antibodies, which in turn activate platelets through their Fc constant receptors, and thereby initiate a prothrombotic cascade. I guess that's a thing. Heparin-induced thrombocytopenia, HIT. It's immune-mediated because it causes a production of an antigen. Antibodies form against complex of platelet factor 4 and heparin. These antibodies bind to the PF4 heparin complex on the platelet surface and induce platelet activation by cross-linking of the parts of the receptor. So it causes platelet aggregation. That's why the platelets levels have been dropping. Usually does not develop until after 5 to 10 days of treatment, despite being associated with low platelets. HIT is actually a prothrombotic condition. Yeah, sort of like DIC, I guess. Disseminated intravascular coagulation, but in this case it's platelet aggregation. At DIC, you also use up platelets. HIT, you also use up platelets, and then you cause clots to form. Features include greater than 50% reduction in platelets, thrombosis, and skin allergy. Address need for ongoing anticoagulation. Direct thrombin inhibitor, danaporoid. Okay. Heparin-induced thrombocytopenia. Oh, Osmosis has a video. Goody. Let's have a look.
Learning medicine is hard. The term heparin-induced thrombocytopenia can be divided into two parts. Heparin refers to an anticoagulant medication which prevents blood clots from forming, and thrombocytopenia refers to decreased number of thrombocytes or platelets in the blood. So, heparin-induced thrombocytopenia, or HIT, is a complication caused by heparin that results in decreased platelets in the blood. Okay, so imagine you're making dinner and accidentally cut one of your fingers. Now, if your body doesn't stop the bleeding, you'll keep losing blood until there's not enough to supply the vital organs like the heart and brain. Now, to prevent this from happening, the body has a process called hemostasis. This process has two phases, primary and secondary hemostasis. In primary hemostasis, platelets aggregate to form a plug at the site of an injured blood vessel. While these platelets are aggregating, coagulation or secondary hemostasis starts. This is where numerous enzymes that are always floating around in the blood, called clotting factors, get proteolytically activated, meaning that activation happens when a small piece is chopped off, a bit like pulling the pin out of a grenade. These factors activate one another, eventually leading to the activation of fibrin, or factor 1A. That results in a fibrin mesh, which forms around the platelet plug to reinforce it and hold it together. Without primary and secondary hemostasis, our body would suffer massive blood loss from even the most minor injuries. Imagine losing all your blood from something as simple as a pinprick. Okay, so heparin-induced thrombocytopenia is caused by heparin. This medication works by activating an enzyme called antithrombin 3, which inhibits coagulation factors 10A as well as thrombin. This halts secondary hemostasis and prevents existing blood clots from growing larger. So it's often given to people who suffer from pulmonary embolisms, strokes, and myocardial infarctions. Now, the main mechanism behind the development of HIT is actually an immune response, which starts when heparin binds to a protein on the surface of inactivated platelets called platelet factor 4, or PF4. Together, they form a complex called the heparin PF4 complex. This complex is immunogenic in certain people, meaning they have circulating IgG antibodies that recognize the complex as foreign pathogens. So, these antibodies will bind to the heparin PF4 complex and mark it for destruction within the spleen. Now, when the antibody binds, it causes the platelet to activate. The activated platelets release procoagulant chemicals like thromboxane A2 or TXA2, which causes other platelets to activate. At the same time, the original platelet will also release more PF4s, so more antibodies will bind and keep it activated. These events lead to more and more platelets getting activated, and they start forming clots throughout the body. This way, a lot of the remaining platelets also get consumed, which results in a low platelet count. Now, when the antibody binds, it causes the platelet to activate. The activated platelets release procoagulant chemicals like thromboxane A2 or TXA2. Bodies will bind to the heparin PF4 complex and mark it for destruction within the spleen. Now, when the antibody binds, it causes the platelet to activate. The activated platelets release procoagulant chemicals like thromboxane A2 or TXA2, which causes other platelets to activate. At the same time, the original platelet will also release more PF4s, so more antibodies will bind and keep it activated. These events lead to more and more platelets getting activated, and they start forming clots throughout the body. This way, a lot of the remaining platelets also get consumed, which results in a low platelet count. It generally takes a week for the body to make IgG antibodies that target the heparin PF4 complex. Thus, thrombocytopenia typically develops 1 or 2 weeks after starting heparin therapy. The exception is that if heparin is given to someone who was already treated with heparin previously, they would already have the antibodies against the complex, so thrombocytopenia may develop within a day. Now, the widespread formation of abnormal clots can lead to life-threatening thrombotic events, which are most often venous, causing deep vein thrombosis. Sometimes, this thrombus can break down, and part of the thrombus, also known as emboli, can lodge into the pulmonary circulation, leading to pulmonary embolism, which is often life-threatening. Thrombus can also develop in cerebral veins, leading to cerebral venous sinus thrombosis. Compared to the venous thrombosis, arterial thrombosis is less frequent. Arterial thrombosis can block the arteries supplying limbs, causing limb gangrene, or brain, causing stroke, or heart, causing myocardial infarction. Now, the diagnosis of HIT is often made clinically along with the help of some laboratory tests. For example, individuals who recently started heparin therapy and experience a decrease in platelet count either within 1 to 2 weeks or within a day suggests HIT. The level of platelets can be found by using a complete blood count, or CBC. Other diagnostic tests include an ELISA serological assay to detect the IgG antibodies. However, many individuals that have received heparin previously will have these antibodies, but not all of them will develop HIT, so the test is not very specific. A more specific test is a serotonin release assay, which is the gold standard for diagnosing HIT. In the serotonin release assay, the patient's serum is mixed with heparin and donor platelets. Activated platelets release serotonin. So in a positive test, the patient's serum has antibodies that activate the platelets, and the serotonin level will increase. Then will develop HIT, so the test is not very specific. A more specific test is a serotonin release assay, which is the gold standard for diagnosing HIT. In the serotonin release assay, the patient's serum is mixed with heparin and donor platelets. Activated platelets.
Patient's serum is mixed with heparin and donor platelets. So the patient's serum contains the antibodies, and then donor platelets will combine with heparin to form the antigen, PF4 heparin antigen. Okay.
Platelets release serotonin. So in a positive test,
Why would it release serotonin? Anyway.
the patient's serum has antibodies that activate the platelets, and the serotonin level will increase. While confirming the diagnosis, platelets and the serotonin. So in a positive test, the patient's serum has antibodies that activate the platelets, and the serotonin level will increase.
Okay.
While confirming the diagnosis, it's important to immediately stop giving the patient heparin and to start anticoagulation with a non-heparin anticoagulant, like argatroban, which is a thrombin inhibitor. If the patient has a thrombotic event, anticoagulation is continued for 3 to 6 months. If there was no thrombotic event, then anticoagulation continues until the platelet count normalizes. Alright, as a quick recap, heparin-induced thrombocytopenia, or HIT, is a condition where individuals on heparin therapy develop thrombocytopenia, or a low platelet count in the blood. HIT occurs as a result of an immune response, which ultimately causes the platelets to get activated and used up during the formation of abnormal clots. These clots can block veins and arteries, leading to life-threatening thrombotic events like deep vein thrombosis, pulmonary embolism, cerebral venous sinus thrombosis, and less commonly, limb gangrene, stroke, or myocardial infarction. Thanks for watching. If you're
Okay. Thanks. Learned something new today. HIT. Okay, next question. You have been asked to review the blood pressure of a 65-year-old gentleman who was recently seen by the practice nurse for his annual health review, and his blood pressure measured at the time was 153/88. There is no history of headache, visual changes, or symptoms suggestive of heart failure. His past medical history includes hypertension, asthma, and gastroesophageal reflux disease. The medications he's currently on include amlodipine, indapamide, lansoprazole, perindopril, salbutamol, and a combined LABA and corticosteroid inhaler. On examination, his blood pressure is 159/85. Cardiovascular exam is unremarkable. Fundoscopy shows a normal fundi. The results of the blood tests from 2 days ago are as follows. So we're just reviewing blood pressure, are we? Sodium normal, potassium normal, bicarbonate normal, urea normal, creatinine normal. Which of the following is the most appropriate next step management for his blood pressure? So what blood pressure medication is he already on? Amlodipine is already on a CCB. Indapamide, it's a thiazide-like diuretic. Lansoprazole, if I'm not mistaken, is a PPI, proton pump inhibitor. Yes, it's a proton pump inhibitor. It's a proton pump inhibitor, as all. Perindopril, it's an ACE inhibitor, so he's already on 3 high blood pressure medications. What's the next step of management? Do we add a 4th drug, or do we refer to specialists? At my level, I will refer to specialists. We don't want to add a beta blocker because he has asthma, right? Yeah, he has asthma. So beta blockers is contraindicated. He needs beta 2 activation. So no beta blockers. Beta blocker definitely out. Alpha blocker, I don't know. What are the guidelines? I will refer to specialists. He's already on ACE, so angiotensin receptor blocker is out. Aldosterone antagonist is out as well. That leaves alpha blocker and referral. I don't know about alpha blockers, so I'll just refer. So I know my limits, but let's see what's the answer. The answer is an alpha blocker. Okay. So let's have a look at NICE guidelines. NICE guidelines for hypertension, diagnosis and management. What we're looking for: managing hypertension, choosing antihypertensive drug treatment, treatment steps for hypertension, step 1, step 2, step 3. Step 3. Let's see step 1 and step 2 first. So if you have diabetes, type 2 diabetes and under 55, you're going to give ACE inhibitors. If you have type 2 diabetes and over 55, you also give ACE inhibitors. If ACE inhibitor not tolerated, give angiotensin receptor blockers. If they are African or Caribbean, give angiotensin receptor blockers as well, because they're known to not tolerate ACE inhibitors. Over 55 ccb. Then after that, you add your ACE. So you add your ccb, you add your ACE or thiazide. Then step 3 is adding whichever is not there yet, either ACE, ccb, or thiazide. Then we're going to step 4, resistant hypertension. If hypertension is not controlled in adults, taking the optimal tolerated doses of an ACE inhibitor or an ARB plus a CCB and a thiazide diuretic, regard them as having resistant hypertension. Before considering further treatment for a person with resistant hypertension, confirm elevated clinic blood pressure measurements using ABPM or access for postural hypotension and discuss adherence. For people with confirmed resistant hypertension, consider adding a 4th antihypertensive drug as step 4 treatment CBO or seeking expert advice. Okay, so I chose to seek expert advice. Let's see what step 4 treatment is. Consider further diuretic therapy with low-dose spironolactone. For adults with resistant hypertension, low-dose spironolactone. Spironolactone is an aldosterone antagonist, if I'm not mistaken. Right. Aldosterone antagonist. Who have a blood potassium level of 4.5 or less. In this case, his potassium was 4.9. So no spironolactone for him. Spironolactone blocks aldosterone, so blocks sodium reabsorption and potassium excretion, so there's a risk of hyperkalemia. So only start if potassium is less than 4.5, okay? When using further diuretic therapy for step 4 treatment of resistant hypertension, when using further diuretic therapy for step 4 treatment of resistant hypertension, monitor blood sodium and potassium and renal function within 1 month of starting treatment, and repeat as needed thereafter. So you either add spironolactone or a diuretic. What diuretic? Consider alpha blocker or beta blocker for adults with resistant hypertension starting step 4 treatment who have a blood potassium level of more than 4.5. Okay, so less than 4.5 add spironolactone. More than 4.5, I would consider either alpha blocker or beta blocker. I'm not sure about what's going on here with the diuretics. Probably somebody with heart failure, you want to add diuretic as the 4th step. If blood pressure remains uncontrolled in people with resistant hypertension, taking the optimal tolerated doses of 4 drugs, seek specialist advice. Okay. So remember, step 1, either ACE inhibitor or calcium channel blocker depending on the scenario. Most of the time you add ACE inhibitor unless they're more than 55 years old and does not have diabetes. You're going to start with calcium channel blockers because in ACE inhibitors you want to monitor renal function, and in elderly their renal function is not that good. After that, you want to add either CCB or diuretics, thiazide-like diuretics. Then there's step 1, step 2, step 3 covered. Step 4 depends on the potassium level. If potassium is high, more than 4.5, you will want to consider either alpha or beta blocker. If the potassium is low, less than 4.5, you want to consider spironolactone. If that doesn't work, seek advice specialists. Okay, poorly controlled hypertension, already taking ACE inhibitor, calcium channel blocker, and standard dose thiazide diuretic, potassium more than 4.5, add alpha or beta blocker. Yep. So patient's blood pressure remained elevated on 2 separate occasions despite taking ACE inhibitor, calcium channel blocker, and thiazide-like diuretic. His recent blood test shows a potassium of 4.9. In this instance, NICE recommends adding an alpha blocker or a beta blocker. As the patient is asthmatic, beta blocker is contraindicated, hence alpha blocker is the correct answer. NICE recommends a low-dose aldosterone antagonist as an off-license use if potassium level is less than 4.5. As the patient's recent blood test shows a potassium level of more than 4.5, low-dose aldosterone is an incorrect answer. NICE recommends seeking expert advice if blood pressure remains uncontrolled with the optimal or maximum tolerated dose of 4 drugs or 3 drugs, which is red. The patient is currently taking 3 antihypertensive agents, therefore the answer is referral is incorrect. Well, depends on each individual, I guess. Angiotensin receptor blocker is an incorrect answer. Should not be used in conjunction with an ACE inhibitor. Okay. Hypertension management. I've just been through NICE guidelines, which is more accurate. Stage 1 is more than 140/90, or ABPM, HBPM more than 135/85. Stage 2 is more than 160/100, or ABPM, HBPM of more than 150/95. Severe is more than 180, or diastolic more than 110. And here's the flow chart. Clinic reading, you're going to diagnose with ABPM or HBPM. Less than 135/85, not hypertensive. More than 135/85 is stage 1 hypertension. Treat if less than 80 years and any of the following: target organ damage, established cardiovascular disease, renal disease, diabetes, or 10-year cardiovascular risk equivalent to 10% or greater. Stage 2, you're definitely gonna treat regardless of age and offer drug treatment. And the drug treatment is here. Less than 55 years or type 2, start with ACE inhibitor or ARB. More than 55 or type 2 or no type 2, start with calcium channel blocker. then add ACE or diuretics. And then you want to have a full house of ACE, calcium channel blocker, and diuretics. And step 4 is depending on potassium levels. If it's low, add spironolactone. If it's high, alpha or beta blocker. If they have asthma, beta blocker is contraindicated. If not, control on 4 drugs, specialist review. Okay, targets. Okay, next question. A 52-year-old male is referred to urology clinic with impotence. He is known to have hypertension. He does not have any morning erections. On further questioning, the patient reports pain in his buttocks. This worsens on mobilizing. Is that sciatica? On examination, there is some muscle atrophy. Something more sinister is going on. The penis and scrotum are normal. What is most likely diagnosis? What does he have? He has hypertension. Has it affected his nerves? It's not psychological. Some nerve pathology is going on there. S3 to S4. If I remember correctly, the penis is S1, S3 to S4. I can't remember. Let's look for dermatomes later, but we'll just attempt the question without searching first. I have no idea what Larissa syndrome is. It's named after somebody, I'm quite sure. Pudendal nerve lesion. Where is the pudendal nerve again? I don't remember. Psychological impotence is out. Beta blocker induced impotence is out as well. It wouldn't cause any nerve things. So it's either a correlation. Correlation should be bilateral. Reports pain in his buttocks. It doesn't say left or right. This is possible. Okay. Pudendal nerve. Probably it will be unilateral buttock pain. It says pain in his buttocks. Both sides, I'm assuming. So I'm gonna say S3 to S4 correlation. Oh, the answer is the syndrome, which I don't know the name of. Larissa syndrome. Classically, it is described in male patients as a triad of symptoms: claudication of the buttocks and thighs, atrophy of the musculature of the legs, impotence due to paralysis of the L1 nerve. It's L1, not S2 to not S3 to S4, huh? Let's look at the dermatomes, human dermatomes. Dermatomes. Look in the penile areas. S2 or S3 is correct, but this is sensory. This is sensory. S3 to S4, S5 is in the anal region. Let's look at the question again. What did it say? S3, S4. Okay, so S3, S4, S1, S2. Here's S2, S3. 2, 3, 3, 4. Oh well. Larissa syndrome is atherosclerotic occlusive disease involving the abdominal aorta and/or both of the iliac arteries. Management involves correcting underlying risk factors such as hypercholesterolemia and stopping smoking. Investigations is usually with angiography. So it's an arterial problem, not a nerve problem. Makes sense. Because not enough blood supply to the buttocks, causing the pain. Not enough blood supply going to the penis, so you can't erect. Hypertension, risk of arteriosclerosis. Muscle atrophy. Doesn't say which muscle, assuming the thighs or buttocks. Okay. So everything is related to inadequate blood supply. Nerve problem would also cause atrophy due to disuse. but probably not S3, S4. S3, S4 motor. Nerves. S3 and S4. Pudendal nerve. What does the pudendal nerve supply? Pudendal nerve. Teach me anatomy. Pudendal nerve is a major somatic nerve of the sacral plexus. Overview nerve roots S2 to S4. Innervates the external genitalia in both sexes and the skin around the anus, anal canal, and perineum. Motor innervates various pelvic muscles, the external urethral sphincter, and external anal sphincter. In this article, we shall look at the anatomy of the pudendal nerve, its cause, motor, and sensory functions. Anatomical cause. Go through the foramen, pudendal canal. So S2, S3, S4 goes through the pudendal nerve. Pudendal nerve supplies the penis, scrotum, rectal area. Motor function, bulbar spongiosus, ischiocavernosus, levator ani muscles. Supplies the perineal muscles. Sensory function. Afferent component. So one thing to differentiate between afferent and efferent component of erection here. This is morning erections. So morning erections, you don't stimulate your penis in the morning to get these erections. It's normal physiology. So it is indicating a motor defect. Pudendal nerve is for the afferent function. For the sensory function. Not for the efferent component. Not for the motor function. Right. It wouldn't affect the buttocks muscles if it's pudendal nerve. There's nothing to do with the buttocks. What supplies the buttocks is the sciatic nerve. Probably wouldn't cause buttocks pain. If that's buttocks pain. Yeah. Pain in the buttocks, I have to think about arterial causes, because if there's nervous problems, there's a nerve problem, it would be more of loss of sensation in that area, not pain. Pain is more of arterial cause. Of course, there's something known as neuropathic pain, but don't think it applies in this way. Oh well, Larissa syndrome, something new. Due to arteriosclerosis. Larissa syndrome, atheromatous disease involving the iliac vessels. Blood flow to the pelvic viscera is compromised. Patients may present with buttock claudication and impotence in this particular syndrome. Diagnostic workup will include angiography where visible. Iliac occlusions are usually treated with endovascular angioplasty and stent insertion. How do you pronounce this syndrome? Larissa syndrome.
Larissa's syndrome.
Larissa's
syndrome.
Larissa syndrome. Larissa. Okay. Next question. Infections. These are different organisms. Please select the most likely pathogen to account for the scenario given. Each option may be used once, more than once, or not at all. A 72-year-old man with peripheral vascular disease develops a gangrenous toe. This becomes infected and there is evidence of infection in surrounding tissues. On clinical palpation, there is crepitus present within the tissues. Crepitus. It sounds like gas gangrene. What causes gas gangrene? Clostridium. One of the Clostridium perfringens, I think. Don't really remember very clearly, but that sounds about right. A 22-year-old lady is breastfeeding her first child. 1 week postpartum, she presents with a tender indurated mass in the right breast. So during breastfeeding, 1 week after giving birth, tender indurated, most likely mastitis. What's the most common cause of mastitis? Staphylococcus aureus. A 45-year-old man is recovering in hospital following a total hip replacement. He develops a profuse and watery diarrhea. Is he on antibiotics? Several other patients have been suffering from similar symptoms, so it's hospital acquired. What is common in hospital that causes diarrhea? I think it's C. diff. Let's see. Correct. Okay. Clostridium perfringens is the most likely pathogen to be associated with gangrene, with gas gangrene. Staphylococcus aureus is a common cause of lactational mastitis. Clostridium difficile can spread rapidly on surgical wards. The use of broad-spectrum prophylactic antibiotics during arthroplasty surgery can increase the risk. Yeah, something that's common because of the use of antibiotics is resistance to the normal antibiotics. Surgical microbiology, an extensive topic, so an overview is given here. Organisms causing common surgical infections are reasonable topics in the examination. Okay, I don't think we have to go through all this. Next question. A 2-month-old girl is brought to the emergency department with her father. Her father reports a 2-hour history of a non-blanching rash over her body. Oh no, is this meningitis? Meningococcal meningitis. He reports that in the past 24 hours she has seemed unsettled, refusing feeds and crying more often than usual. Observations reveal temperature of 38.6 degrees Celsius and examination confirms the non-blanching petechial rash with generalized hypotonia. Examination also reveals a bulging anterior fontanelle, everything pointing towards meningitis. Given the most likely diagnosis and following appropriate investigation, which of the following would be the most appropriate initial management option? Where is she? She's in a hospital already. Initial management option, how old is she? 2 months. I don't remember the guidelines. There are guidelines for this, which I don't remember. Cefotaxime and dexamethasone. I think is dexamethasone required. It will reduce intracranial pressure, especially if you have bulging anterior fontanelle. That will help. theoretically, but everything is based on guidelines and can't base everything on theory. It is real practice. So intravenous cefotaxime. So cefotaxime appears quite commonly. So cefotaxime is the antibiotic for the meningitis. What other? Amoxicillin? Do we need amoxicillin? I don't think so. Let's try this one. Oh, the answer is cefotaxime and amoxicillin. Okay. Do not use corticosteroids in children younger than 3 months with suspected or confirmed bacterial meningitis. Oh, okay. I didn't know that. Luckily, I learned this before becoming a doctor. This clinical picture points to a diagnosis of acute bacterial meningitis in a child younger than 3 months old. The most appropriate treatment option here would be IV cefotaxime and IV amoxicillin. IV cefotaxime is useful to cover for pneumococcal and Haemophilus influenza. Okay, remember the organisms, right? Neisseria meningitis, NHS, Neisseria, Haemophilus, and Streptococcus. However, children less than 3 months are at risk of listeria. Gel. Less than 3 months is gel, I think. G for what again? E for E. coli, L for listeria, G for gonorrhea? No? But I don't think so. Anyway. Therefore, without amoxicillin cover for this, there would be an inadequate cover. So less than 3 months, you want to add amoxicillin to cover for listeria. Okay, IV dexamethasone is given in cases of bacterial meningitis. Unless the patient is younger than 3 months, it helps reduce the risk of neurological sequelae. Why do we not use in under 3 months? No explanation here. It's better to read nice guidelines for these kind of things, right? In children, meningitis under 16, meningococcal septicemia under 16, pre-hospital assessment and management, There's a mostly history and examination, transfer to secondary care, notify because it's a notifiable disease. When non-blanching rash is present, you want to give IM or IV benzyl penicillin. This is when you haven't reached hospital. Withhold benzyl penicillin with clear history of anaphylaxis after a previous dose of it. When rash is absent, you don't give any antibiotics. Unless urgent transfer to hospital is not possible, then you give it in the primary care setting. Then refer to secondary care. Investigations, you're gonna do the sepsis things, right? The blood culture and all that. Ceftriaxone. Is this for this is not for everyone. Ceftriaxone is for those over the age of something. Give intravenous ceftriaxone immediately to children and young people with a petechial rash if any of the following occur at any point during the assessment. Petechial rash starts to spread, rash becomes purpuric, signs of bacterial meningitis, signs of meningococcal septicemia, appears ill. Gonna do these tests. High risk clinical manifestations. Blood tests, CRP, white blood cell, CSF, PCR. CT. Use clinical assessment and not cranial CT to decide whether it's safe to perform lumbar puncture. CT is unreliable. If it's performed, do not perform a lumbar puncture if the CT scan shows radiological evidence of raised intracranial pressure. Do not delay treatment to undertake CT. Clinically stabilize before CT. If performing, consult senior. Lumbar puncture, primary investigation, unless contraindicated. Don't delay antibiotics because of a lumbar puncture. You want to look at the white blood cells of the CSF. Stain it. Glucose measured. Do not perform lumbar puncture if any of the following contraindications: shock, raised intracranial pressure, spreading purpura, convulsions, coagulation abnormalities, superficial infection of the site, respiratory insufficiency. Management in secondary care. Treatment with antibiotics. Here. Treat children and young people aged 3 months or older with suspected bacterial meningitis without delay using intravenous ceftriaxone. So more than 3 months, ceftriaxone. Younger than 3 months, use cefotaxime. These are all cephalosporins, plus either amoxicillin or ampicillin. Okay, remember this. More than 3 months, ceftriaxone. Less than 3 months, cefotaxime plus amoxicillin or ampicillin. Without delay, using ceftriaxone. If they have recent travel outside the UK, add vancomycin. Calcium-containing infusions are being administered. Do not use ceftriaxone. Instead, use cefotaxime. Okay. Younger than 3 months, ceftriaxone may be used as an alternative to cefotaxime, with or without ampicillin or amoxicillin, but be aware that ceftriaxone should not be used in premature babies or in babies with jaundice, hypoalbuminemia, or acidosis, as it may exacerbate hyperbilirubinemia. If tuberculosis meningitis is part of differentials, use an antibiotic appropriate for it. Herpes simplex meningoencephalitis part of differential, give antiviral treatment. Okay, this is after the culture, I think, once you know the organism. More than 3 months, Haemophilus influenza is the organism. Give ceftriaxone for 10 days. Streptococcus pneumoniae is the organism. Give ceftriaxone for 14 days. Younger than 3 months. GBS. Yeah, G stands for GBS. Okay, younger than 3 months. The common organisms are group B Streptococcus. And the mnemonic is gel. So group B Streptococcus, E. coli, and Listeria monocytogenes. Then after that, after 3 months is NHS or NS. I remember correctly. It's in the guidelines. These things. Group B strep. Give cefotaxime for 14 days. L. Listeria, amoxicillin or ampicillin for 21 days. Plus gentamicin. Gram-negative bacteria with cefotaxime. What's the gram-negative? E. coli, huh? E. coli is gram-negative. Yeah, so if E. coli is cefotaxime. Unconfirmed. Ceftriaxone. Younger than 3 months. Cefotaxime plus ampicillin or amoxicillin. Okay. Goody. So, in meningitis, depends on the age. If more than 3 months, you're gonna give ceftriaxone. If less than 3 months, you're gonna give cefotaxime and amoxicillin to cover. Amoxicillin is to cover for listeria. What are the common organisms? I remember the mnemonic gel, NS, and NHS. I forget which is which. So, 4 weeks. Why 4 weeks? This is not the one that I studied. It's through slide shares, probably not very reliable. Slide share again. Where's the one by nice? Let's just search it from here. I think we need to download the PDF version. Oops. Am I revealing my stuff? Oh well, who cares? Go to downloads. Downloads. Where is it? Bacterial meningitis. This is the one. Oh, you can't see it because it's out of this. Switch to laptop screen capture. Adjust the size a little bit. Sorry for this, guys. Didn't really plan for this. Okay, now I can see my desktop. Okay, center it a bit. Right. Management, treatment of antibiotics, additional investigations. Where are the common organisms? It's not here, is it? No, it's not here. Common organisms, where are you? It's not here. Oh, well, switch back. Where do you find it? Anyway, we can find something similar and try and remember what I actually learned. Here, this one looks similar. So less than 3 months, GBS, GBS E. coli, gram-negative bacteria, and listeria. Where's the listeria? Not here. But if you see the rash, it's definitely Neisseria, right? NHS, Neisseria, meningitis, Haemophilus influenza, and Streptococcus pneumoniae. And then NS, Neisseria, and Streptococcus pneumoniae after 3 years. Yeah, I think that's it. Logically, if you have a rash, you're quite sure it's Neisseria meningitis. Why are you not giving ceftriaxone? You can give ceftriaxone according to the guidelines. Oh well, just follow guidelines. Cefotaxime and amoxicillin. Okay. Should we go through this since we already went through nice guidelines? Just to reinforce our knowledge. Yes, let's go through it. Meningitis in children investigation, management investigations, contraindication to lumbar puncture, any signs of risk, intracranial pressure, focal neurological signs, papillar edema, significant bulging of the fontanelle, disseminated intravascular coagulation, signs of cerebral herniation. For patients with meningococcal septicemia, lumbar puncture is contraindicated. Oh, I see. Blood cultures and PCR for meningococcus should be obtained. Meningococcal septicemia, that's meningitis, Neisseria meningitis, you call it meningococcal septicemia, when it affects the blood. So you don't do lumbar puncture if there's sepsis. Or it's Neisseria. Is it because Neisseria causes higher risk of raised ICP? Blood for PCR of meningococcus should be obtained. Okay. Management, antibiotics less than 3 months, amoxicillin plus cefotaxime, more than 3 months, ceftriaxone. Or cefotaxime. But NICE guidelines say ceftriaxone, so we just follow NICE. Steroids. NICE advice against giving corticosteroids in children younger than 3 months. Oh, I missed that. When to treat with corticosteroids. Okay. Do not use corticosteroids in children younger than 3 months with suspected or confirmed bacterial meningitis. Give dexamethasone 4 times daily for suspected confirmed bacterial meningitis as soon as possible if lumbar puncture reveals any of the following. It doesn't say why either. Do not start more than 12 hours after it. I'm getting a little hungry. What time is it? 2:20. Let's try to go a bit more. Dexamethasone should be considered if lumbar puncture reveals any of the following. Frankly purulent CSF with white blood cell count greater than 1000 microliter. Raised CSF white blood cell count with protein concentration greater than 1 gram per liter. Bacterial and gram stain fluids trigger any shock with, for example, with colloid. Usually you use crystalloids. Cerebral monitoring, mechanical ventilation if respiratory impairment. public health notification, and antibiotic prophylaxis of contacts. Ciprofloxacin is now preferred over rifampicin. Oh, that's something new. Before this, I knew it as rifampicin. No, it's Cipro. Ciprofloxacin. Is it ciprofloxacin now? Discharge and follow up, I think. We'll just trust PassMedicine on this. Next question. A 23-year-old gravid on para 0, so currently pregnant. First pregnancy, female is brought to the GP clinic for evaluation for her acne on her face and chest. There has been no itch or scaling. The patient is concerned about facial scarring and is determined to get treatment. She feels embarrassed about going out into public. She has a background 3-year history of mild acne and has been treated with topical benzoyl peroxide in the past with minimal clinical improvement. She has no other past medical history and is not on any medications. She is currently 18 weeks pregnant and with an uneventful normal pregnancy thus far. On examination, she appears well with stable vital signs. Her body mass index is 23. Is that low? Normal. 18 to 25 is normal, right? BMI normal ranges. 18.5 to 25 is normal. Okay. Yes, 23 is normal. There are visible open comedones on the face and upper chest, and pustules can be observed from several comedones. The comedones are surrounded by generous erythema. She does not complain of any tenderness on these skin lesions but feel uncomfortable when wearing clothes over these lesions. Which of the following is the most appropriate initial treatment? So she's pregnant. A lot of medication cannot be used. Isotretinoin is out. This teratogenic. Vitamin A is teratogenic in pregnancy. Topical benzoyl peroxide she's already tried. Oh, initial treatment. What severity is her acne? Face, upper chest. Face and upper chest. 3 years of mild acne. Pustules. Generalized erythema. Is it still mild or is it already moderate? And what is the initial treatment? Tetracycline, I think, is one of the options because QT bacterium acne is the bacteria that causes acne. So it works. Tetracycline works, I think, such as doxycycline. Spironolactone, I'm not sure how that works. I don't think it's used in acne. Oral erythromycin. Erythromycin, is it helpful in acne? I'm not sure. Benzoyl peroxide. So one of the first line, you know, the Oxy-10 that you use to dry out that area. I'm gonna say tetracycline, but she's pregnant. It's safe to use tetracyclines. On the safe side, just go for benzoyl peroxide, but I think I might be wrong. Yeah. The correct answer is erythromycin. Oral tetracycline should be avoided in pregnant breastfeeding women and in children younger than 12 years of age. Let's look at tetracycline. What is it? Tetracycline. It's an antibiotic. Bacteriostatic broad-spectrum antibiotic. It's used in pneumonia, UTIs, STDs, skin infections, especially acne vulgaris. Let's look at the mechanism of action. Overdose pharmacodynamic properties. Tetracycline hydrochloride is a broad-spectrum bacteriostatic antibiotic. Tetracyclines are taken up into sensitive bacterial cells by an active transport process. Once within the cell, they bind reversibly to the 30S subunit of the ribosome. So it affects the ribosome. You don't want that for pregnant women. Hence, cell growth. It inhibits photosynthesis and cell growth. So that's why you wanna prevent using it in pregnancy. I mean, contraindicated in pregnancy. Tetracycline will give permanent teeth discoloration. So it should not be used during pregnancy or lactation. Not to be used in pregnancy unless essential to the patient's welfare. Across the placenta, it may have toxic effects on fetal tissues, particularly skeletal development. So tetracycline, no in pregnancy. Acne vulgaris is a common skin disease that appears as comedones in a common location such as the face, chest, and back. These comedones can develop into inflammatory pustules or papules in moderate to severe disease. Oversight. In moderate to severe cases, classified as inflammatory acne. So this is moderate to severe. It often requires oral antibiotics due to the risk of further complications such as scarring. Topical benzoyl peroxide has comedolytic and bactericidal effects that are used to treat mild acne. This patient has trialed this topical medication, trialed this topical medication. However, the acne has progressed to moderate severe inflammatory acne, and therefore topical benzoyl peroxide alone may be ineffective. Topical benzoyl peroxide alone may be ineffective. A previous use of topical benzoyl peroxide has also shown poor clinical response. Oral antibiotics such as tetracyclines are used to treat acne via an anti-inflammatory action. However, tetracyclines are teratogenic and should be avoided in pregnancies or breastfeeding women. Tetracyclines associated with permanent teeth discoloration in the fetus and enamel hypoplasia. It also is also associated with maternal hepatotoxicity. Patients who require oral antibiotics may use erythromycin, which is safe for use in pregnancy. Okay. So erythromycin works for acne as well, huh? Oral spironolactone is an alternative acne treatment option to antibiotics. However, it's not safe in pregnancy. Yes. Renal problems, right? Should be avoided. I didn't know that spironolactone can be used. Topical isotretinoin may be used in combination with other topical oral agents for mild to moderate acne. However, it's not safe for use in pregnancy or breastfeeding women. Okay. Simple step-up management scheme. So first, either topical retinoids or benzoyl peroxide. Combination, then oral antibiotics, tetracyclines, diamylacine, oxytetracycline, and doxycycline. Avoided in pregnancy. Erythromycin may be used in pregnancy. Minocycline, less appropriate due to the possibility of irreversible pigmentation. Single oral antibiotic should be used for a maximum of 3 months. Topical retinoid, if not contraindicated, or benzoyl peroxide should always be co-prescribed oral antibiotics to reduce the risk of antibiotic resistance. Topical and oral antibiotics should not be used in combination. Do you use topical antibiotics? Gram-negative folliculitis may occur as a complication of long-term antibiotic use. high-dose oral trimethoprim is effective if this occurs. COCP alternative to oral antibiotics in women. As with antibiotics, they should be used in combination with topical agents. Dianet coxyrendiol sometimes used, as it has anti-androgen properties, has increased risk of VTE compared to COCPs. Generally be used second line, only be given for 3 months. Counsel about the risk. Isotretinoin only under specialist supervision. Pregnancy is a contraindication. There's no rule for dietary modification. No, this is wrong. Now new evidence has shown that you can advise reducing, what do you call that? Cutting out the milk stuff. Dairy products, yes. Cutting out dairy products in your diet. It will improve your acne. Okay. Let's just see how erythromycin works. Erythromycin. It's used in upper respiratory tract infections, lower eye, ear, oral, skin, acne. Pharmacodynamics. It also affects the ribosome, but the 50S subunit. Works against listeria. Works against gram-negative. Works against mycoplasma. Works against chlamydia. Syphilis. Pregnancy. There is no evidence of hazard from erythromycin in human pregnancy. It has been widespread use for a number of years without apparent ill consequence. Animal studies have shown no hazard. Erythromycin has been reported to cross the placenta barrier in humans, but fetal plasma levels are generally low. Erythromycin is excreted in breast milk, therefore caution should be exercised when erythromycin is administered to a nursing mother. Okay. So it has been used a long time and no problems so far. So it's quite safe in this respect. Although it does cross the placenta. Next question. Which one of the following is least recognized as a potential adverse effect of electroconvulsive therapy? Least recognized? How do I know which one is least recognized? Nausea. Short-term memory. I know this is a side effect, but is it least recognized? Epilepsy is the least recognized one. Although electroconvulsive therapy by definition causes a controlled seizure, there is no increased risk. Least recognized as a potential adverse effect. You should ask which one is not a potential adverse effect. Although electroconvulsive therapy by definition causes a controlled seizure, there is no increased risk of epilepsy in the long term. Okay, the key here is knowing the other side effects. So nausea is definitely a side effect. Cardiac arrhythmias as well. Short-term memory impairment is a commonly known side effect, that's why I know it. And headache. And epilepsy is the odd one out. That's why that's the answer. It's probably not a potential adverse effect of electroconvulsive therapy. Okay, electroconvulsive therapy is a useful treatment for patients with severe depression refractory to medication, for example, catatonia. Those with psychotic symptoms, the only absolute contraindication is raised intracranial pressure. Short-term side effects: headache, nausea, short-term memory impairment, memory loss of events prior to the ECT, which is same as memory impairment, cardiac arrhythmia. Long-term side effects: some patients report impaired memory. Okay, that's all for today. Thanks for studying with me. Gonna end this stream. It's my first stream. Just private. Oh well.